Good evening, everybody. Thank you for attending. I'm Ashley from W9. Tonight we've got a great webinar to listen to from Dr. Peter Fairburn and Dr. Minas Leventas regarding commonly asked questions and answers for EthOss, whether it be procedure-wise, product-wise. They're going to go through quite a broad range of questions tonight, which should be good. And any questions that you have during the webinar, please feel free to jot them down in the questions box that's available in your little control panel. And I will bring them up at the end if we have time. If we run out of time, I will be sending your questions to Peter via email, and you will get correspondence from me with the answers when he has answered them for us kindly. So without further ado, I'd like to thank Peter again, and please, the floor is all yours.
Right, thank you very much. Thank you, Ashley, and thank you everyone in Australia. And I'm looking forward to coming down again in March. And I've just had a really good time in the Far East. So yes, there's a number of questions, and there always are, because essentially we're looking at a different procedure and a different protocol on how things are done. So we're looking at things in a completely different way. What I'm going to do is show a few slides just to get a couple of ideas across. Then I'm going to go through this long list of questions that I have. And then we'll answer questions of yours at the end. Okay, so I'm just waiting for Minas, but when he arrives, he'll arrive at maybe just traffic getting in this morning. And I'd like to thank Ashley, Arc Health, W9, all our distributors in Australia. So yes, in last August, I had the opportunity to speak on the main stage, the ICOI, and I'm speaking at the next World Conference, the ICOI, in Taipei in September the 5th. And it's been interesting because what's actually happening is that our protocols, our ideas, our concepts, and the way we're working is now being seen on a much wider scale. And, you know, a lot of things have been happening for EthOss, but mainly happening for the protocol and the way we've been working, which is a more symbiotic approach to implant dentistry and regeneration of tissues. As you know, we published the protocol in 2015, and this protocol is using an extraction 3 to 4 weeks, implant placement and grafting, loading at 10 to 12 weeks. Right. The weird thing is that the more I'm actually seeing and the more people I'm seeing, I've noticed that people are using the material all in their own different ways. And this is just dentistry. Everyone interprets or prefers a way that they're used to using. I prefer subperiosteal healing, subgingival healing, but a lot of people are placing collared healing caps and that getting a seal that way. A lot of people like Costa, in same-day implants in Dubai, he uses it immediately on every case, and then they give immediate temporaries, and they get final restorations 1 week later. So he's pushing it to a completely different realm and having great success in this area. So yes, I'll try and show some other people's cases as well, just to show this variation. Sorry, I just pushed the wrong one. But really, the success to all bone grafting materials. You know, people sometimes say, oh, I could lose material. Yes, you can lose material in all procedures. The keys to the success lies in the basics of surgery and bone biology. So these are the two things we always need to think about. Am I getting my surgery correct? And do I understand what I'm trying to achieve and what I'm trying to set out to do? Now, EthOss itself, a lot of questions are asked, and we can start right off. I've got a list of about 40 questions, so we want to go through everything. And I get the first question, does it contain freeze-dried bone, and how much? No, EthOss is a simple mixture, and where I got the conceptual idea is from orthopedics, and what I'll mention later on is on PubMed and high-impact medical and scientific journals. Up to a couple of weeks ago, there were 128 new research papers using beta-TCP alone in medicine. And this seems to be the big direction that they're going in medicine. So it's essentially a beta-TCP product with a small amount of calcium sulfate, which acts as a built-in barrier function and helps to stabilize the graft. Look, the benefits of calcium sulfate are well known since the 1892 with Driesman. They're biocompatible, stable, bacteriostatic, and we get improved soft tissue healing. And they bioabsorb at 3 to 4 weeks. What this early bioabsorption, so you can't just use calcium sulfate itself like bonbone, because it'll resorb too quickly and prior to any bone formation. But this early resorption is good because it provides nutrients for the mineralization, but most importantly, it creates the space for further neovascular ingrowth into the site, and this leads to increased angiogenesis. So this is the important fact, is blood. Blood is bone, blood is healing, blood is oxygen. And these are the things that we really want to make sure. And this is why I've never used a membrane in the last 18 years and 6,500 grafts. Another question we go straight on to is particularly interested in the site preparation and closure. Yes, this is an important aspect, and I'm going to go through a little bit with you. And how do we stabilize the graft with sutures? And another one is, he looked at a case where I put the implant into a socket filled with graft, and how is the pathology removed? Yes, what I like to always use is degranulation burrs. This is why it's really important, and I feel this is one of the reasons why the standard socket grafting cases, occasionally people can have failure. Because what actually happens is they've just taken an acutely infected tooth out, they wiggle an instrument roundabout in the socket, and they say it's clean now, and then they pack a graft on top, and they're packing the graft on top of granulation tissue, which may be very infected granulation tissue, and this may preempt the loss of graft material, any graft material, or prompt a sort of a encapsulation of graft materials by this fibrous granulous tissue in the site. So when we talk about socket grafting, you'll see we prefer a procedure of actually taking it out, letting it heal, and then raising a flap at 3 to 4 weeks, cleaning the site, and then you'll end up with a very, very solid ridge with no loss of dimension in 10 weeks later. Now, yes, I know it makes 2 procedures. Someone said to me in one of the questions, why 2 procedures? Now it started to heal with the clot. But a lot of times, if you have a very infected site and then you open it up even 2-3 months later, it's still granulous. The healing procedure is slowed down significantly. And this may lead to also a loss of the volume. So the whole concept of why it's at the 3 to 4 weeks is that stage we can get soft tissue closure, so improved periosteal coverage, improved healing, without the hard tissue loss, which only starts, according to all the research by Schropp and Agalou, at 5 to 6 weeks. So that's why the timing is as such. So yes, when we actually do the pushing case, which a number of people asked me about, that is because of we don't need to have primary stability or bone to implant contact. And there's a lot of research about that at the moment as well. And the reason why the calcium sulfate acts as a barrier, if you look at the picture on the left, you can see the calcium sulfate is covering the beta-TCP particles. And when we brush it away, you see the beta-TCP particles underneath. Now, these beta-TCP particles have a nice porosity and also regular shape, and that also helps stabilize the graft. So the actual inert stability comes from the shape of these particles, and then the calcium sulfate on the outside will further stabilize in the initial period and also help act as a barrier function. I don't believe that there's soft tissue ingrowth, but there's a number of reasons for that. But the way that the calcium sulfate works, it's made synthetically, and it's a dihydrate. And then basically, sorry, some lights just went on there. Everyone's arriving for work. And then essentially, it's through a process of calcination, it's heated up and it forms a hemihydrate. When you mix saline with it, yes, stick to saline, don't mix blood. Some people I know have mixed PRF and getting great results. I prefer to use the PRF over the site rather than mix it in the site. And then there's a process of enucleation, which is actually the first bits of the hemihydrate turning to a dihydrate. This then turns over to, and that is when the crystals start forming. And this takes longer than we think, probably 5 to 10 minutes, so that then we get crystallization where there's more particles turning over. So, and then the whole product becomes more stable. Now, I'll go through that further because that's really important on how we're going to make the material harder and set harder when we want to do a buckle build out to get stability. Okay, so that's an important aspect to understand. There's another question here. As a patient had a failed implant right after placement, in other words, non-integration, so it was a spinner, and he needed to move the implant. Can I preserve the socket with EthOss? Yes, you can. I normally, if in this situation, this year, fortunately, I haven't lost a single implant, so I had having a good run. Changed to any ridge, and I've been very happy with the integration of the implants. But again, as you know, with everything, those are just tools. With this graft material, it's a tool, it's a golf club, it's like a rescue club. So you've got to learn how to and know how to play the game. So with a failed implant and a non-osseointegration, I normally take the implant out, let the site heal over for 3 weeks, go and curette the site, and then graft with EthOss. I'm going to show you a case later on, so we won't dwell on that too long. In the case of large lower posterior bone augmentation with G-bone, what you experience is a limitation. Yes, there are limitations in this area. Lower mandible is the one area. Upper on the maxilla, I can grow vertically, horizontally. We can do many things. We can get results on the lower mandible, the posterior mandible, but stay away from that initially until you're actually more experienced. Yes, we're doing a lot of tunnels now. I'm not going to show you, but if you look at EthOss case studies, you'll see what we're doing, and we're getting really quite impressive results. And now we're looking at long term. I never like to show things unless I have at least 5 years follow up with that technique. I know everyone on Facebook likes to show what they did yesterday, but they don't even show what happened tomorrow. I don't show anything unless I can get predictable, 99% predictable outcomes over a 5-year period. So it's important for me to say that because I'm a dentist, like everyone else. I'm sitting in my office here, and essentially we're alone. We're having to work by ourselves, and it's important that we pass on information to each other that we know that we can predictably outcome. Yes, there are differences in techniques, and sometimes that does take a little bit of getting used to. Can I use EthOss on a media implant and a healing cap that seals the socket? Yes, Dominic Kohuli does that all the time on his cases. And if you look on case studies, all of his cases, you'll notice he does the same, all immediate, all with a healing cap, and he gets great results. And as I say, that's the great thing about it. And that's why the product is not delivered in a syringe with a set amount of saline, because the mixing protocols can be varied a lot. So I often make wetter mixes, drier mixes, and I often take the material out of the syringe and mix it outside. So this is a very important part, which we'll go through about the mixing. Yeah, and yes, often it's recommended that once we've done extraction, it's better to let the body to heal with the bleeding and the natural process, and graft materials can impede this healing because of the stem cells. Yes, I agree it does, but what we're trying to do here is prevent volume loss. Now, this volume loss can be incredibly varied, and it's varied by many factors, and that's patient physiology and the severity of the pathology before. You know, sometimes you take a tooth out, let it heal over 3 months, and you've lost no volume. And the next time you do it, and at 2 months, you look at it and you've got no keratinized tissue and you've got no volume. So we just go on to the next slide briefly. And I was with Nick Matthias in Bangkok, who's now next leaving the University of Hong Kong. But you know, this I said to him, look, I always use this because this is important. The list of the ideal properties of a particular graft. And I love osteoinductive, conductive, biocompatible. I like the way it's totally replaced by bone. Look, these are the ideals set by, you know, Yip and Matthias and Lang at the top university in the dental school in the world. And the appropriate resorption time in line with bone formation, maintaining graft stability. And this is what we like about the material. And the only one I can find is beta-TCP. And this is why our medical colleagues are really excited about beta-TCP at the moment, because it seems to be the material that has the highest osteoinductive potential. Yes, look, there's over 200 papers on PubMed stating that calcium phosphates are osteoinductive. It's a given fact in medicine and in bone biology that they are. This is all known. And, you know, now even Danny Booser and Rick Myron have been publishing it. So let's just take it as a given. Yep, so the single stage surgery, I always like to place the implant at the same time. As you can see in a lot of my cases, even if I've got low or no primary stability, I will place the implant into the graft, even if it's not really touching the host bone. I'm not saying for you to do this to start off with until you get used to the materials, but this has been the most successful thing that I have done with the material. So it seems to be very predictable in my hands. So it's something I do every day. I've done 3 or 4 in the last month. It's just been one of those times where the cases have been quite bad that I haven't been able to get any stability. There's a question here about stabilizing the EthOss graft with sutures. I'll go into that. You know, the whole idea is you've got to remember that when we're talking about augmentation and regeneration, they're different kind of procedures. Regeneration is using the host. When I talk about regeneration, I mention the fact that only the body can regenerate my bone. Look, I don't have a regeneration center. I'm not a guru. I'm not some master that can regenerate other people's bone. I can only regenerate my own bone. So I don't have a regeneration center. My regeneration centers walk in my practice and they walk out again. It's simple. I can't do it. Their body's got to do it. So it's all about understanding how the body heals and how things actually work. We're just looking again at the next slide, and this is about calcium phosphates, angiogenesis. This is a high impact medical journal, 12.5. And again, this is the key that they're looking at in medicine and bone. Physiologists as such are looking at the whole concepts on how these calcium phosphates are upregulating the host healing response and improving angiogenesis. It's a great read. If there's one paper you read, I think it's this one. It's nice to read. And it's good to get away from really just looking at low impact dental material and trying to get a better understanding of everything. Look, again, it comes up about another question here is about animal origin. No, there is no animal or human origin. And this is why I got involved in it, because of Alistair Cook, an English journalist whose body was stolen in New York, you know, in 2004 or 2003. People loved Alistair in the UK, and so every patient came in and said, I hope you're not putting Alistair in me, because the American Bone Bank was corrupted by the mafia effectively, and the products were not sterilized or not clean. At that moment, I decided that I now will not use anything from a donor sort. Not that I don't like, I'm not vegan. I love having a steak probably as much as any good Aussie. A steak and a beer. I'm a king around the barbecue, being South African. But it does make getting consent easier. The patient asks you, what are you putting in me, doc? And we can say, I'm putting in something that was synthetically made that'll turn over to your own bone. And you know what? Yes, they like that, you know. There was a question about the collagen sponge used over the top in one of our studies. Yes, it is of animal origin. The reason we did that is that when you're actually doing studies, you have to do what everyone else is doing to make it comparable. So yes, there are some nice synthetics, EthOss. There's some nice synthetic membranes. Do I use a membrane? No, I don't really. And another factor is I very rarely soft tissue graft. I do probably maybe 10 soft tissue grafts a year, and I do hard tissue grafts 2 to 3 a day. So I generally help the body heal the hard tissue, let the body fix the soft tissue itself. Okay, so this is about site preparation now and suturing. So we're going to go through this. I'm just going to show you a little bit here. And you can see I like using these degranulation burrs just to clean the site properly. So you can see on the other pictures how we have clean, healthy bone. I'm not raising a big flap because we're not putting in a whole lot of material. So we're only putting in a smallerish amount. So we don't need release. You know, I always say in my lectures, yes, if my mum-in-law walks in, we can release it a lot more. But the whole thing is about healing, oxygen, and keeping the site, cleaning the site, and allowing the body to do the healing for me. So I need the periosteum up against the healing site, so not overgrafting. Okay, here I'm showing good and bad because there's a good papilla sparing incision on the one side, and on the other side up against the lateral, I've done some bad surgery there. I've cut through the papilla, and you will see the effect of it in this case. So now I'm just placing the implant here. I'm placing a Pel-top implant. You can see I'm correcting the angle. I do like the new Southern implants with coaxis. I like the coaxis aspect because then it allows me to screw retain. And a lot of the referring dentists prefer screw retained implants. You can see we're not over grafting with the EthOss. Now you see that material, that mix is quite hard. The way I actually get a hard mix is I take the material out of the syringe, mix a small amount or mix half of it, and that makes a wetter mix. I then place that deeper in, place the implant. I then mix the other half, the unmixed half of the hemihydrate with the dihydrate and with the minimum amount of saline. We then get a real sticky like putty, which you can hold your instrument upside down and it won't fall off. And this then sets much faster because we can skip the enucleation phase and we can go straight into the crystallization phase because we already have completed the enucleation by adding dihydrate to the hemihydrate. This means that it sets faster and it'll set harder. So then you just place the material, get your nurse to hold on to it with a dry gauze for a few minutes, probably give it a little longer until you get used to it. Then we suture closed. I prefer nice clean sutures like monofilament or here PTFE. And you can see I start at the papillary area and then I pull it closed so that there's a little bit of tension there, but the suturing to the palate is going to be tension free. Can you see how I've left it open? And against the lateral, you can see where the bad surgery was. You can see we've now got an area. Then I put one loose suture over the palatal just to hold the flap down. Here it is 5 days later, and you can see when we're removing the sutures, you can see the good healing already. And you see on the palatal aspect, you can see the healing by secondary intention, even at 5 days. And you can see the healing by secondary intention up against the lateral. All right, so you can see how the body heals. You can see if you saw the pre-op, I'll show you the pre-op photograph at the end. And you can see how it's healed nicely. And here it is 6 months loaded, and we've got an adequate outcome. There it was before, and there it was afterwards. Okay, so I've done no soft tissue. I just extract the tooth, let the host heal, raise the flap, graft, and loaded at 10 weeks, and there it is loaded 6 months. So it's an okay result. And we did the extraction, which wasn't obviously very difficult. And all we've done is done one surgery where we've lifted a flap up and restored. Okay, let's go back to some questions. Your recommendation is to do socket preservation at 2. Won't this aid the collapse of the socket? No, it doesn't. we get fantastic results, and you'll see with socket grafting, if you do it in the 2-stage, it makes it 99% predictable. Another question, your suggestion is not to have a membrane on top of the scaffolded material. In other materials, such as the xenograft, I'm not going to say trade names, the role of the materials to not allow connective tissue encroachment in the socket. How can we be sure? Don't worry, it actually works very well. There is no soft tissue ingrowth per se. I think this was just devised by a couple of guys over a few beers. I think that the reason why we had encapsulation of the cow material, of the xenograft, was threefold. A, not proper cleaning. B, micromotion of the particles, so the mesenchymal cells differentiated to fibroblasts rather than osteoblasts. But most importantly, the xenografts are seen as a foreign body, and so you have a foreign body giant cell reaction, and this tends to encourage the host to encapsulate those foreign body materials. This is why we need to have always need to have a membrane when you're using xenografts, is to prevent this recognition of the foreign body and to stop this encapsulation. So this is why we don't need it. EthOss is incredibly biocompatible. 95% of my patients don't have any painkiller the following day, and that includes on sinuses. So we don't feel we need the membrane, and they don't use membranes very often in medicine. And it's a simple thing, is that we all understand that the miracle of all of this process is the periosteum. The periosteum is not just the blood cell, but the periosteum is the reason for the healing because of induction. Periosteum stimulates induction of stromal cell-derived factors, which are the most important BMP for the bone healing on the basis is that what attracts the mesenchymal cells to the site. So this is why I simply don't have a problem. I do these cases every day, done 6,500 over 18 years. I have never used a membrane. Yes, I've used it occasionally, very rarely I use a titanium mesh, but never a membrane. Membranes will hinder healing when they're used, and this is why the healing process takes so much longer. Look, we can look at EthOss sites at 6 to 8 weeks, and there's already bone formation, new bone formation. This is because we are letting the body do what it does best, and that is heal. The body will heal despite what we're doing. Okay, we're no miracle. We're just guys who just come in and do work. So we've got to remember that the less we do, the better the outcome. Okay, we talk about fibrous encapsulation without a membrane. We never see it. Don't worry. I haven't had a single failure this year, and it just works. It just works that way. Let's see. Question here. Someone said to me, "Look, Ferb intends to load at 2 months from implantation. Where are there any situations where you would vary this period?" Yeah, look, I just do every case at 10 weeks. I tell the patient come in at 10 weeks. Sometimes I load earlier in sinuses because I think we get better results. I do use Ostel or Penguin to measure the integration of the implants. But if you read the research by Sasaki, which is used in syncretology, and it shows how the implant upregulates the host healing, by just placing the implant, we're going to get an improved regulation of bone metabolism. Loading early, we get a secondary spike. And his research showed that the implant was actually also integrated at 4 weeks. So I think we're still learning a lot about it. There's a really good book about titanium in medicine, which is good to read. For those grafts that have failed, what is the protocol in response? We don't have many. I've had 5 or 6 where I've just added extra graft on, open the site, clean it, and add a little bit of graft. Got a question. My experience with BCP is more post-op discomfort post-extraction, and he's put in brackets, use bond bone from MIS. Look, bond bone has got no beta-TCP in it, so I'm not sure, and I'm not sure why you get this pain. We don't have any post-operative. I understand the holy grail to regenerate as close to nature as possible, but whilst the common sense is prevail, as evidenced by those histological reviews of grafted sites, is there evidence that clinical outcomes placed in different bones actually affected differently, crystal bone loss? No, I think the ideal, this is why I think that there's a less chance of periimplantitis, because we're returning the bone back to what they would have been before. So the bone actually is a living material. It needs to turn over. So if we placing foreign material, it inhibits the ability of the bone to turn over. And this can eventually lead to the bone dying. Yes, some of the more senior members of ITI had done studies showing that in actual fact there was no osteocytes in the bone after 10 to 15 years. So what osteoconductive? Look, all materials have osteoconductive properties. They're acting as a scaffold. But the key is the osteogenesis and the upregulated effect. So therefore, I generally don't use PRF. I can use it over the top. But I find that these materials have an osteogenic upregulating effect. Look, going back to the slide, as dentists, we like to use our hands. But let's try and actually use our minds to get healing. Because yes, a lot of these materials that we're using, the xenografts, they're big chunky things. Yes, it's much easier to use them to fill the hole up. But what are you doing? You're just putting bricks in the hole. Yes, it makes it easier to get a result in some ways. Oops, sorry, that meant to be bone. It just changed shape. But by putting all of these foreign materials, it's logical. And my kids would look at it and say, yes, Dad, but by putting all these lumps of other stuff, you're getting a lot less of their patient's own bone, which is logical. But it does help mechanically because, as you know from building a concrete wall, it's harder to build something all out of bone. So we're using little techniques like this with PDS sutures to help stabilize it. And also it's important to make sure we understand the motion of the muscle tissue. How brittle is the in situ around the implants? Look, the whole idea of by using a fully bioabsorbed material, all the material will turn over to host bone, and we find that we get a higher percentage at all our studies show 50% new bone at 10 weeks. So we actually get a slightly more dense bone because there's a lower connective tissue component. The next question is, how soluble is EthOss in biofluids? Yes, bleeding is essentially the proteins may affect the set, may stabilize. So these are all about just developing your own skills. Materials a lot better and easier functioning than ones I used to use before. Yes, the vertical bone growth does help with papilla regeneration, and I've shown lots of cases in my lecture where we look at things in the long term. What's the exciting thing about EthOss and EthOss regeneration is that over the long term, we get an improved bone formation because it's helping the host upregulate. So I look at the papillae over a longer period of time, and it looks better. So I'm just going to run through a quick video. We'll go for about another 15 minutes. And this is just using, that's a standard 3 weeks post-extraction. And you can see doing a frenectomy first of all, just to make sure, then just for making incisions. A lot of people say they don't like vertical incisions because they scar. Well, yes, there is scarring technically, but I've shown and debated with a lot of people that there's nothing even at 10 days. I can hardly see it. Now, on the palate, you can do split thickness to full thickness. When you're raising the flap, you always have this connection to the granulation. Just be careful. Can you see, rather than tearing the periosteum will heal amazingly fast. This is the whole thing, is we've got to understand how we're going to work with healing. Then you can see we've got this area of degranulation, so we curette that. And then again, we're just curating the site, and there's me just using degranulation bursts, taking all the loose bone as well. The thin bundle bone will be lost, and this will compromise your aesthetic outcome. So rather remove the thin bits of bundle bone, and then we can graft. And all our cases and published cases, if you look on ethos.dental, you'll see published cases there. Then I'm just placing the implant at the correct level. And you can see we're not placing it too plately. It's a restorative job. We don't want big overhangs. Nick Mattias was talking about big overhangs and the effect on the periimplantitis and issues in the future. So it looks, you know, I'm placing the implant where the tooth would have ideally been, the root, because I want the correct restoration. And as you can see, just placing the implant, and then all we're going to do is graft with it. I would normally place now into a wetter mix of EthOss, then make a drier mix. Can you see how this is a drier mix? Can you see how it's got a slight putty? See, now having to force the material down, in actual fact, it would be better to have placed it into a wetter mix and then get the drier mix on the outside. So this brings the whole thing about micromotion and leading to fibrous tissue. You know, when we look at this particular video, can you see what's happening there? Look how it's pulling the gums. Look how it's moving everything. Look at it after we've done a slight phenectomy. Okay. Sutures, I can take them out as little as 48 hours. Again, the calcium sulfate element is very, very good for soft tissue healing. There's the sutures. There they removed it, 48 hours. Okay, that's just 2 days. And here's the case loaded 1 year later. And yes, look at the papilla. Look at the papilla mesial to it. That papilla had been lost. I'd cut through it. So yes, as time goes, if you look at the x-ray, you can see how the bone has regenerated, how the host has helped further regenerated the bone. If you look at the bone in that mesial area, you can see up against the adjacent lateral, and that's why we have papilla formation. Okay. What should I use for socket preservation? As I say, socket preservation, I'll show you a case. Other guys just do it the normal way and they get great results. I want to give you 99% result. I say you take the tooth out, let it heal, flap it, clean it, graft it, and put the flap back over, and you will get 99% success rather than be open to the vagaries of the mouth. Because that's the big problem, is when we socket graft, the patient walks out of the surgery, you know, they're off, they go to the pub, they have a few beers, they party, they jump around. So it's better we have control, and the best way to have control is to be able to put periosteum over them. Should I use EthOss and periimplantitis? Look, I could show you in Malaysia, most of the cases they use it in is in periodontal issues, and they're getting amazing results. Yes, because it's bioabsorbed, turns over to host bone, it's the best form of treatment, but you've got to treat the periimplantitis cases properly. Take the crown off, let the tissue heal over, razor flap, 360-degree cleaning, graft, flap it again, let it heal for 10 weeks. Right, I'm going to go on to a few sinuses, but here what we've got is a fractured implant. You can see a fractured dio-UF here. I tried using Neobiotech, it just broke more of the implant off. So I had to trefine it. Here it is being trefined out. There's the defect. Can you see just a small amount of EthOss? We've lost the buccal wall as well. Here it is at 10 weeks. So now you can see we've got a nice healed site at 10 weeks. There it is, placing the implants, now using any ridge, and that's the outcome at loading, which is adequate. Here's looking at a traditional socket graft. As you see, we've done a covered with a fleece because we are publishing this. We have a lot of research on healing by secondary intention over. So just in 10 weeks, that's the beginning to the end. And look at the new buccal plate. The buccal plate was lost. Look at the new thick keratinized tissue. If we help the body heal the hard tissue, the body will do the soft tissue for us. Okay, here's just looking at it. You can see there it is grafted. Now, when we look at this, it looks like we're losing the graft, but we can only see what we're seeing on X-ray if it's radiopaque. So this is a pre-mineralization, plus we're losing the calcium sulfate element at 3 to 4 weeks. Here's at 10 weeks. You can see it's now mineralizing and turning back. We take a core. This is the entire core. This is not just taking a good corner. And as you can see, over 50% new host bone from the center of that socket at 10 weeks. Why? Because we've allowed the body to heal. This is a simple process, nothing complicated. Put an implant now in the middle, 69, it's loaded. This case is loaded now a few years. And here we look at the bone growing around a beta TCP particle. So it's fully turning over to bone. This is regeneration. And here's a scan at 2 years to show the case. Can the EthOss be used in cases where a previous graft has failed or had a defect? Yes, it can, but you've really got to clean the other material out because there's often a lot of granulation around that as well. Can local be used when mixing? No, stick to saline. It's better to do it that way. I know often, I sometimes at the end of it, I fill up some small syringes of saline to use where I'm not going to be doing a big implant. Well, how do I use EthOss? This is what we've been going through. Best way to get EthOss to firmly set is as we've shown. Look, this is a case by another dentist, Johnny Cochran, and a young guy in the UK, and he works completely differently. What he's going to do here, socket graft, just put a whole lot of vicryl sutures over the top, and there you can see a week later the sutures and the healing. Here he's raised it 10 weeks later, and you can see the site, and you can see how he's maintained the ridge proportions. And with the fluted drills, you can see the new host bone. Placing the implants, again, he obviously likes vicryl and uses a lot of it. Look, this is what he does, and it's working for him. And here's the healing caps, there's the site, and there's the case loaded. So it's an adequate outcome. He's had a nice result. Maintained the ridge, he's got nice keratinized, maintained the keratinized epithelium. Look, it's not just keratinized, it must be attached keratinized. And the only way you're going to get attached keratinized is not by doing free gingival grafts, it's by allowing the host to do the making of it, to improve the tissue for you, because you've got live bone underneath. Okay, and this just shows a failed implant here. It's done in Thailand. You can see I've let it heal for 3 to 4 weeks. There's the site cleaned out afterwards. Okay, there it is, looking at the x-rays, and loaded 2 years now. So, and that is the end result at 10 weeks. So you can see we've got a nice new ridge to put the implant in, and this is important because we have host bone. That's a really important factor. We're just looking at another difficult, just do another 5 minutes. You can see where the sinus is at the top. It's just at the top of the buccal roots there. We've socket grafted, placed the implant at 8 weeks here. Here's 10 weeks later. Look, the implant's completely covered in bone. We needed a round burr. Here it is loaded 6 months, and loaded a year. Look how the host has regenerated the bone, because you've got to remember that was the site before. This is important. We've avoided a sinus lift here. We've got the host to regenerate for us, and that's an important aspect. Socket graft, sinuses, yes, I use them in every sinus. I've used synthetics in sinuses for 20 years. I've done sinus augmentation in 1 to 2 cases every week, laterals, internals, for a long period. I have never had an infected sinus in the 25 years that I've been doing sinus augmentation. So it seems to help because the materials are bacteriostatic. I can show you me using them in infected sinuses. We don't have a problem. Here we took the roots out, and we had a very thin plate. And yes, I was just trying to do it all in one go, and I pushed it into the pilot into the sinus because it was only 1 millimeter and I was into the sinus. So I just socket grafted the site, and I was just put some over the ridge. And here it is 10 weeks later, and then we placed the implant using Versa. This is at 10 weeks later. So that's the new bone that you're seeing at 10 weeks. So it gives you the flexibility that you now don't need to use a lateral window. And we could, 2 choices for internal. We can use the internal desk, or I use now more is Versa, so densification. And you can see now when we're using EthOss and densification, make a very dryer mix, not too dry that it's crumbly, but make a more solid dryer mix, and then we just reverse it in. Okay, and then we place the implant, place a little more graft. There's the end result. It's okay. There it is on X-ray. Lateral windows, yes, I still like doing them every now and again. You do need to have the skill, because if things go wrong or you lose an implant or a root in the sinus, you've got to know how to get these things out. So there's a nice DAS lateral window. I've grafted through the osteotomy on the crestal surface. As we're placing the implant, you can see the graft material is being pushed buccally. Then I use a dryer mix. Can you see that nice dryer mix to seal the window? Here's the x-rays. You can see at the process. And there it is at 12 weeks, or I think it was 11 weeks this case. And you can see it's there. It is restored. If you look at it, can you see we only had 2.5 millimeters of bone at the placement level. And if you look at it, you can see a nice new crestal plate there inside the sinus. This is because we have a nice upregulated host response. Right, there's a couple more questions. So I've gone through about setting it firmly, maybe possibly more. Someone said I might be possibly interested in the product if the product material is good, effective, multiple situations, evidence-based, many different studies. Look, if you want to use evidence-based, there's some cow materials that have got 1,000 papers. This is newer. It takes a little bit of time to get the ideas. But if you look at the high impact journals and move away from low impact dental journals, which are industry controlled, you will find that there is a ton of evidence towards beta TCP, and even more so now. So, you know, it depends. If you want something that's got 20 years of evidence, you know, stick to your Nokia. The Nokia has been a really effective phone for many years. The iPhone 11 is new. It doesn't have much evidence. So things take a lot, but where we must look, if we really evidence obsessed, is look at what's going on in medicine and in bone physiology research. So this is what, you know, this is the thing about research. We've done a lot of cases. There's a lot of other cases. You visit case studies. How long has it been recorded? I've been using similar materials, orthopedic materials, for 18 years, and EthOss for the last 6 years, 7 years. There's no way I would, as a dentist, put anything on the market that I wasn't getting predictable outcomes with on a daily basis. So a lot of people say, yes, are skeptical about using it as it is highly resorbing in some cases. Well, that's the whole idea. That's what makes sense. That's what the doctors like about it. Look at here. This is St. George's. This is where we're selling a lot to NHS hospitals for MaxFax. This is a nice email I got the other day. Our entire head neck deformity unit is now using EthOss. They use it in conjunction with other materials, yes, because they need to fill up much bigger spaces than we're doing. And as they say, they'd love to face post failures, but it doesn't seem to be a problem. So I must go up and go and see them at St. George's, which is the main deformity and you know, post-trauma sort of facial unit in the London area. So they seem to be happy. These guys, #2 ranked dental school in the world as well. Here, this is from about 6 months ago. They seem to be happy. You know, we seem to be making headway without throwing a lot of money at it, without having the key opinion leaders of the world. But it's exciting. A lot of people are coming to us and saying, we're getting exciting results. So, you know, for us, this is interesting. For me personally, it's been a long journey, and you know, it's always more complicated to try and not contradict, because I am contradicting. Yes, I'm contradicting ITI and contradicting the older school, but I'm not contradicting what's more important to me, and that is called logic and biology. These are the two most important things. I don't care what someone else is selling. I don't care. I mentioned it to Bob, you know, Bob Sullivan in the States when I was with Georgios Romanos, and he was saying great results, but he said, we sell X million dollars worth of membranes. I don't care. The body doesn't need them. This is just the way things are. This body's going to heal despite them. I know it means some people are going to make less money, but to me, that's not important. What is important is biology and healing. The suppliers, I think Ashley can fill you in on all the suppliers. Someone asked, who are the suppliers in Western Australia? I'm not sure, and I'll leave Ashley up to do that. And I'm going to start questions now from the floor. Final answer is what the difference is when compared to BIOS. Well, look, they're completely different materials. You know, I mean, you don't even compare them. They're doing completely different roles. EthOss is a regenerative material, and that's the big difference. And you'll see that EthOss is there merely to help the host regenerate bone. Okay, so we can't, and this is why it's taking longer to get FDA approval in the States. It's hard to compare against any other dental materials. We have to be looking at the orthopedic world where these materials are more routinely used. Okay, and so that's it, and it was brilliant. On Friday night, we had a good reason to do a lot of drinking. We won the Small Business of the Year in the UK, just showing our global growth. We're now over 50 countries globally, and it's been quite an interesting ride. Just have a look. That's my email address. Anyone can contact me. That's our website, www.ethos.co. And the interesting thing is to join Facebook, join the EthOss case studies. That's the practice I work in London. If you want to join us, there's a couple of pubs nearby. We always like a drink, but I cannot leave this program without saying thank you, and thank you to ARC and W9. And I cannot leave without saying that, because as a South African, this was the highlight of the year, and it's going to take another 4 years for you guys to have another chance. But in the meantime, we're the world champions. Thank you very much. I'm just going to hand back to Ashley now so that she can give some further questions we may have. Thank you very much.
Thank you so much, Peter. That was great. And I hope everyone got some of their questions answered. That I have had a couple come through, so I will go through them.
Sure.
If just quickly touch base on this one, because I know you did, but I got the question of what is the rationale of not grafting the same day as the extraction?
You know, you can, but you become, I want to have 99% protocol. I have grafted the same day, and I've shown 2 cases where we did graft the same day, and Johnny Cochran grafts the same day on all these cases. I just sort of feel that with a lot of cases, you can lose any graft material because you become dependent on what your patient is doing. They can go out, go to the pub, have 5 pints and fall over drunk. And that's happened to me. And it means that my work is taken out of my hands. And that's why I like it. Plus, it's easier to clean. Sometimes the patients have had a traumatic situation by having the extraction already. And yes, the results we get are really that good that I say I get 99% predictability. Thanks.
Fantastic. The next one, is there any periosteal release of the buccal flap, i.e. cutting the periosteum to gain tension-free primary closure?
No, you see, I prefer to leave the attachment because the blood supply, the main source of blood supply to the bone is actually from the periosteum. But if you're not having to put too much, this is the key, is to not overgraft. And as for closure, if you're going to leave it slightly open, leave it on a site slightly away. In other words, more lingually and more palatally. So I'll make an incision more palatally. You can start split thickness, go to full thickness, and you can leave it open, as I showed in that one case, and it will heal by secondary intention without the loss of any material.
Wonderful.
But big releasing flaps, I know some people like them and soft brushing, but I kind of believe we want to do as little as we can. And I haven't touched on tunnel grafting and what we're doing in those directions. So, you know, that's another whole day, really. Thanks.
Okay. What speed do you use your degranulation burrs at?
I use them at 800. The manufacturer says 1200, but I prefer running at 800 or even a little slower. Just with taking it down to just light use of saline, say 1 or 2 on the physio.
Right. After socket preservation graft, what happens if the patient doesn't continue with the implant? Would the bone still resorb, leading to loss of ridge height and width?
Yeah.
If this procedure be slower than compared to non-grafting?
Yeah, look, that can happen, and that's especially in the sinus. People don't realize the massive pressure of the sinus in pneumatization is more than a lot of muscle pressure. So therefore, if you're not going to place the implant, say for a year or something like that, then the idea is I do mix HA, and I was going to show occasional cases where I mix HA, and that's also in Pontic development sites, and I was going to show partial extraction therapy and using of EthOss, but we just have limited time, and none of the questions mentioned partial. I know Cameron in Australia does a lot and does some really interesting ideas and some interesting thoughts, because a lot of these things are about trying to let the host do more of the work, and we impede the healing as much as we can. Thanks, Ashley.
Great. There is a couple of others which I will send over to you to get some
answers. You can ask probably another 1 or 2.
Another 1 or 2. Okay, I will. What have we got here? I think this one's
Yeah.
similar to the last one. When raising the flap, do we need to perform periosteal releasing incisions for
Yeah,
tension-free?
no. To a point that you're comfortable with. And I had this debate about vertical scarring, and I just did a case recently, and at 7 days I couldn't even see the mark. Yes, there's scarring histologically because soft tissue, unlike bone, you don't get scarring in bone because bone is constantly turning over. Unless you put foreign material in, that may impede it, and that may lead to effective death of the bone. But in soft tissue, yes, you always get a little histoloid, but I generally can't see them because it's all about your suturing and your techniques as well. So, it's important to know the basics of surgery.
Excellent.
Right. Have you got one more? And then
No, I don't have any more. I do have one.
I'll tell you what, let's leave it at that anyway. And then you can talk to, and then send any further ones, or people can contact me, delegates can contact me. And another factor is that I'll hand back to you, and then you can explain the distribution, because a number of questions were about distribution, because I know in Australia you have a key distributor and then sub-distributors. So it's better if you talk about that. Okay, thanks a lot,
I will
Ash.
go through that. Thank you so much.
Thanks a lot, everyone, and see you in 4 years. You can have another go, guys. All right, thanks a lot.
Thank you so much.
All right, bye-bye then.